what I'm going to talk about, when we did the little survey thing, one of the things that people were asking about were a couple of the trays that we have in the recess room. People are always concerned about working with the tray trays and the open chest trays. So that's the ones that concern the people the most because they're the big emergency situations. So I thought I'd make a couple of poster boards and just kind of go over them and we can have a discussion about it. So with the emergency cryo trays, those are the failed airway type patients. So first a little bit about just basic airway management in the, when we're doing a recess. Doc number one is always supposed to be the one taking care of C-spine precautions in the airway. But they also have, if your doc number one isn't the fellow or up there on the list, that they need to be involved. Because if you have a patient that has a tenuous airway, you don't want a doc number one who's very inexperienced trying to make all the calls. So make sure to get the fellow or the attending involved with the airway management. Remember that the ED residents, if they're like a second year or higher, can intubate the patient if they're acting as doc number one. They have to call, or someone has to call, usually it's them, they're pretty good about it. If it sounds like it's going to be a patient that they're going to need to intubate, they need to call their attending to come up and be their backup. I think that we all know that there's the RSI kit that's in the thing. Anesthesia usually brings their own drugs. That's one of the differences between having an ED guy and the anesthesia people is that we have to draw up the drugs for them. So make sure you ask what they want. They usually use etomidate instead of using succinylcholine. They like to use rocuronium. So that's kind of the difference between when we have an ED patient and we have an anesthesia patient. We always assume that all of our trauma patients, they always have C-collar on, but you have to make sure that doc number one takes care of the C-spine during intubation because they're going to want the collar off. You need to have someone kneeling behind them in bed and holding that C-spine. In the past, they've asked us to hold the cricoid pressure. We're like, we're not really quite sure what we're supposed to be doing and how hard do you press and where exactly do you press. And so they have said that it should be the fellow. It got to the point where people were asked, we've had a couple of aspirations, in the past. And so it's supposed to be the fellow or the attending that's actually doing the cricoid pressure. So you'll see Jeannie Lee come in there and she's really good about it. She's like, I'm doing the cricoid pressure. But, some of the other ones are a little more lackadaisical about it. But I don't personally like to do the cricoid pressure anymore. I don't think it's appropriate for, sometimes a second RT will come in and do the cricoid pressure. It should be a doc, and it's supposed to be the fellow or attending that's doing the cricoid pressure. They're supposed to hold the cricoid pressure on that patient until the cup has been inflated and the tube has been verified. So you have a patient, it's one of those things where the doc is looking around, he's like, oh, I'm not sure if I'm seeing what I'm seeing here, and it goes down the wrong place, and vomit starts coming out of the ET tube, and you're going through that whole procedure. We've all kind of been there. So the rule is that they get 3 attempts to put that tube in, and usually how it's supposed to work is that the ED resident or the anesthesia resident gets a couple of attempts. They'll do it. If it's not in the right place, you get out, you bag them, they have another attempt. If it's not in the right place, they take it out. And then it should be the attending, the ED attending or the anesthesia attending who makes an attempt. But now we've got a couple of, adjuncts that we can kind of use, that we didn't have in the past. So just remember that these things exist. So one is an LMA. Anesthesia is pretty good about it. If they're having trouble getting an airway in a person, if they have a lot of secretions or they have a weird anatomy and they're having a little trouble, if they can get an LMA in there and they can actually ventilate well, it's a lot more effective than just regular back valve mask ventilation. I remember once they're having a ton of trouble intubating a patient and the anesthesia's like, why don't we just leave this in here? I've done 2-hour cases where I've had an LMA in there and we should, and I'm like, no, that is not, that I would not take any patient down to CAT scan with an LMA sticking out of their, mouth, paralyzed, really. So that's just kind of like something to help the bag valve valve mask ventilation. It's kind of like along the same lines there, just to reoxygenate the patient to get another attempt in. We have the glide scopes in there now. Just remember that there's two pieces that they kind of need. One is that plastic disposable piece, and that is disposable. You know, there's a bag of them that's, you know, hanging off the glide scope. The other piece is the metal stylet, and that is not disposable. So we have to keep that, and that gets autoclaved and comes back to us. What that is, it's like a little video monitor. They put the tube in, and they can actually see on the screen the vocal cords and watch the tube go through. It's especially good if they have weird anatomies and stuff, and also if they have a lot of secretions. It's a lot easier apparently to see on the big little screen there, the vocal cords and the tube passing through. So that's another thing that you can use if you have a difficult airway.
Is that metal thing hanging on it too? I don't really know.
The little stylets, yeah, they're the blue,
wrap sterile
yeah, like a sterile, yeah, wrap looking thing. So they'll ask for that. It's also up to the attending if they're having trouble getting an airway, like maybe you have an LMA in there and you're ventilating the patient pretty good, but they're like, like maybe it's a semi-bad burn patient, or they have like a big hematoma forming there, and the airway looks kind of sketchy to begin with. But they're doing a good job on ventilating and oxygenating the patient. They may say, call the attending to see if we can get the bronch card in here. And so if they feel they have time to do that, and that's the safest thing to do, they'll go ahead and call and get the bronch team and try to intubate them over a bronch. And you've seen how they do that. They actually go down with the bronchoscope, they get that giant, well sometimes they use bushi, but usually it's that, the tube changer. And they like put it right, that long thing, take the bronch out and then put the tube through. So those are the things that we can use before we actually get the tray out. If you're starting to use these things and it's kind of tenuous, have the tray available for you. You don't necessarily have to open it. They're like, open it up, we're having a little issue, but we can really be the judge of that. The tray takes like 2 seconds to open up. So if it really comes down, we're going to crack that patient and you get the tray out. So I'm not in any way saying that we need to become a scrub nurse and learn what the names of these damn tools are or any of that kind of stuff. But it's just people kind of want to know, what are some of these tools? What exactly are they doing when they're using the cric tray? So if you're having trouble, you're unable to get in, they say get the cric tray out. The number 11 scalpel should be taped on the outside. And that's one of the reasons why we don't need to open it immediately. Yeah, give them the scalpel, they put some chlorhexidine or they pour some betadine. It should be chlorhexidine these days, but a lot of people like the looks of it. Pour some betadine on. So they'll, prep the area. They can go ahead and start getting the sterile towels or doing the incision. If they're really having a bad time with the airway, they're not ventilating, they're not oxygenating, who cares about the sterility, let's face it, they need an airway. So they can go ahead and start the incision as you're opening up the tray. This is the basic things that you'll see in a tray. There's actually more stuff on there because in our trays, it's not just an emergency cric tray, it's a true tray. But these are the most important things. So you'll have the scalpel on the outside. There's this little tool that they actually hook around the cricoid membrane to pull it up and to stabilize the trachea. And then the rest are just like retractors. There's different types of retractors. Some are bigger than the other, and it's just a preference thing. So what they do is here you can see they'll make the incision, and then they'll fold up the trach, and they'll open up the area to have the membrane there, the cricothyroid membrane. They'll slice through that, and they'll use this little dilator tool to open up the hole large enough to put either a trach tube, like a Shiley trach tube, like a number 6. Usually that's what we put in. If it's a tiny person, they may ask for a number 4. That's not included in the tray, so you need to make sure to have that with you. Or a lot of times they'll just use an ET tube. So they'll use a smaller ET tube, usually a number 6. They don't like to use like a smaller one, like a 4. You read in a lot of papers, just put a number 4 in. But it's really difficult. You can't bronch through those tubes, and a lot of those patients that have really bad airways, they need to be bronched and stuff. So we try to put a minimum of a size 6 into the holes. And what they'll do is they'll just put it in the hole and put up the balloon. If they're going to use an ET tube, they're like super long, they're kind of flopping all over the place. If they know they're going to use it as a trach, when they're prepping, they can actually cut it and take the little piece, because it's the same size the whole way. It's not like it's, you know, thicker and gets thinner at the neck. They can slice it to a shorter length and put it on before they put it into the neck. So that's the whole thing. And then you check placement. Just like you do with anything else, you need to check your end-tidal CO2, you need to look for the rise and fall of the chest, and you need to check the lung stats. All right, so things to remember. The only time that we really put a surgical airway in is if we're unable to ventilate and oxygenate them. So it could be because of failed intubation attempts. It could be that they have so much, so many facial fractures that they're afraid that they can't protect their airway. It could be due to some kind of obstruction in the upper airway. But if we're unable with our normal things to ventilate and oxygenate them, that's when we'll actually pull out the trach tray and do the emergency clap. So that's pretty much it. So those are the most common reasons for it. Make sure if you make one, I know that we've been like really, Jonathan is really a stickler about, wear your PPE. But this is one of those times where your personal protective equipment. He loves, every time he looks at a film, he's like, I saw a nurse in there that didn't have their yellow gown on.
Yeah, and he's,
so, yeah, he's in the office watching every trauma. So. Anyways, but this is one of the times that you kind of want to make sure to have it on, and even eye protection. Of course, I haven't done a lot of emergency crites, in the recess room, but of course the one that I'm in is, never forget it, it was Hoyt and Dr. Vasquez. And Vasquez, what does he do when he's making the incision? Slices right through the thyroid artery, and then it was a bloodbath. It was a friggin' nightmare. So, a nightmare.
Jack Yang did one years ago, and he did it so fast. I was still getting stuff ready.
Yeah.
And it was so good.
Yeah, and bloody, it's like a beautiful,
No.
and I was there with, I think Regner did one, and he was like that, and it was really, so it doesn't have to be bloody, it doesn't have to be scary, it really runs smoothly. But every once in a while, you get the bad thing, so be prepared for it. So they can nick something and they can start bleeding, and then you'll probably have to get a recess tray, because there's not a ton of stuff to help, like vascular clamps and stuff like that in a tray, emergency tray. If time permits and the patient is like awake and stuff, like maybe you have a person that just has an obstruction and they physically can't get a good airway in them, so they need to cricum, but the patient is awake and everything, try to medicate those patients. Make sure, try to have the time to give them like local anesthesia at the site. You don't want someone slicing in you when you're asleep. But when the patient is completely obtunded and out, a lot of times you just don't have that time. So once again, check the placement, and a lot of times they'll want to make sure that you'll have like a replacement trach with the whole box with all the pieces in there, or a replacement ET tube and a trach tray at the bedside when you transfer that patient, because it's a pretty tenuous airway. Within 24 hours, or they hope within 24 hours, they'll convert the crite into a permanent trach. So they should go back to the OR within 24 hours if they're stable enough. Up to 3 days is pretty much okay, but they really want to try to do that within the first 24 hours. What it's supposed to help is with subclonic stenosis, because you can develop a stenosis if it's higher up, in the cricothyroid cartilage as opposed to down lower on the trach. But a lot of research is showing that really doesn't happen that often, but it's a lot more comfortable to have the actual trach lower on your airway than up here in the cricothyroid. So what can you see? You can have bleeding even after the whole procedure is done, so make sure that. You can have hematomas form, in the area if they might have nicked something, so look out for that. Look for sub-Q air. There's every once in a while, they can actually put it in and they create a false lumen, so it's not actually in the trachea, and it may just be in the tissue, so they'll have sub-Q air. You won't be able to ventilate and stuff for that. That's why we check for placement. when they're putting in a regular ET tube, the easiest way for them to do it a lot of times is they'll get, you know, one of the blue bougies, and they'll like stick that into the airway and then put the actual ET tube over that to make sure it goes into the actual trachea and not create a false lumen. Watch out for obstruction. They can still aspirate. They can still get vocal cord injury from having the procedure done. If the technique is poor, they can have esophageal or mediastinal perforation or thyroid perforation. So those are all like technique issues that can happen when a doctor is putting it in. So I talked about going back to the OR. Sometimes, if like we've had a couple where the patient was like perfectly fine, you know, almost, and we could not get an airway, and then he started to desaturate and all that kind of stuff, and just because he was so big or his anatomy, and we ended up cracking him. And I think that they didn't even like redo his trach; they just kind of decannulated him and like a little thing, and kind of went on his way. So they may not have to go back for the revision if everything is fine, and they're awake enough to maintain their airway. And that's it. Any other questions on like the emergency crack? Has everyone here had to do one? Yeah, it's not a comfortable
They do it. I
thing.
haven't seen them in a while.
Yeah, and I think just because we have a lot more tools to be able to do it.
It's kaleidoscope.
The kaleidoscope is
Yeah.
great. And I think that LMAs, I had one that we were having a ton of trouble, and they just stuck that LMA in there, and we were able, it was like sweet, ventilating them, got them back up, and they kept on trying, and then got the kaleidoscope out, you know, and the patient never dropped his sats, never looked uncomfortable. It was really nice. So it's nice to have these things, whereas when we first started,
The other day one came in with Ellie, and it was great, because there was oxygenated just fine,
and nothing's going into the stomach, and you know,
Right.
because that's the worst when you have the combi tubes, and when you have the,
Our belly was like,
yeah, exactly. And that's a nightmare, because the second you try to pull that out or do anything with it, yeah. So, all right. So that was that. And God, I hope I'm not taking too long.
there's more.
Talking an hour. Okay. So here's the emergency thoracotomy. So when are we supposed to do these? Usually we're hoping that it's an OR recess, you know, and that it's done. It's all being done in the OR. It's so much nicer to have it done there. But of course, sometimes they come to us. So you're supposed to, the times that you're actually supposed to go through the whole thing and do an emergency thoracotomy is with penetrating thoracic injury, where they've had some kind of cardiac activity or some kind of vital sign before the patient comes in, or they come in and they have unresponsive hypotension, which is like less than 70 millimeters of mercury despite vigorous resuscitation. That's a penetrating thoracic injury. If they have a blunt thoracic injury, they have to have a vital sign before they witness vital sign somewhere before they come to the hospital. If you put it in a chest tube and all of a sudden like a couple of liters comes rolling out, a lot of times they'll go ahead and just open up the chest then. Or once again, if they're continue to be hypotensive despite all the fluids in the blood that you're giving, you go ahead and get it out. And that's just kind of like what I've kind of seen around here. The American College of Surgeons says that the only time is, you know, when you have a precordial wound, so you have to be very specific as to where it is, and they have to have a cardiac arrest. They have to be in the emergency department with some kind of vital sign and then arrest there. Otherwise, it's kind of a white collar situation. And they really don't say that you should do it if the patient is a blood trauma patient. There's just no evidence to show that if a blunt patient arrests and comes in, that doing a thoracotomy is really helpful. So that's pretty much on that. So the tools that you have on the outside of this kit, again, there should be a number 10 scalpel, and that's the one that they use to actually make the incision. It should be like right below the nipple line and follow the rib. And it should be the fourth or the fifth intercostal space, which is kind of high up. Like if you look at someone big like me, they always want to like cut way down here, but it's pretty high on the chest that they actually cut open. The heart's a lot higher than you think. So they'll open it up, and then there's these Metz or Mayo scissors that will be in the kit, and this is the top layer. So when you're imagining, when I know that you did the big open chest one, and it's definitely, I mean, it's almost like in boxes in different layers. But this thing is made out of different layers too. So the top layer is just the access layer. These are towel clips to kind of make your field. You'll have the meds to kind of go through the tissue to separate the tissue out. And then once you separate the tissue and cut an opening there, you get the finishettes in. The way it's supposed to go, and I know that everyone, there's been like, they come apart, they're in two pieces. So this separate piece is not on there. One time we had an open chest code. The doctor put the thing on backwards, so the little arms are supposed to obviously go like this, but she had it on so the arm wasn't going the right way and it wouldn't like open the chest, and they yelled at us, "You should know how to put it together." No, that is not for us to know how to put it together. But if you see someone fumbling around and putting it together, so these arms aren't going to open up the chest, maybe you're like, I think you're right that thing. So that that's all. That's kind of all I figure our job is to be. Another thing is that they suggest that this part, the part that actually ratchets, is down here at the armpit, not up here. And that's because it opens the anterior portion a little bit better, and it's really helpful if you end up having to go all the way across to the other side. So that's all I'm going to say. The little ratchet part should be down by the armpit, and the little finishette, the little arms have to be able to go out this way, or else it's not going to work. The next little layer are all of the things to help clamp. These are the big things for aortic clamping, so that's one of the things that they may do. They may immediately just clamp the aorta. This is a little compressor device. I don't think that they have this thing in our kits. I think that they just have these Statinsky clamps, and they'll just clamp the aorta. The doc should tell you when they're clamping the aorta. The reason that they do that is because if there's any injuries below it, it'll decrease the blood flow to those, so they're not exsanguinating somewhere below where you're at. But it also helps increase the flow to your brain, your coronary arteries, your upper extremities, your all that, your vital organs above the level of the injury. So the doc usually tells you to do that because a lot of times when you're doing a level 1, you're giving them like tons and tons and tons of fluid. Once you cross clamp, a lot of times, all of a sudden, you don't have to be giving them a ton of fluid, and they really don't want you to be doing it at that time. So when they cross clamp, look at the vital signs closely. You might be able to slow it down. They'll tell you when they're going to uncross clamp, and then all of a sudden, the next thing you know, the blood pressure falls, and you're doing it all again. But that's a good communication to have with the doc if you're doing an open chest code. I think that's pretty much it as far as the procedure of getting in. Things to remember: light is always an issue. Even with our fancy beds that have the overhead lights, it's kind of on the side, so they may need to have the other light to come in just to give them a little bit better lighting. Remember the internal defibrillator paddles are on top of the. Right now they're kind of sitting on top of Pete's cart right now. I think both sets are sitting there. So if you have to use those, you give them sterilely, and they'll give you the end that you put into the Zoll. Remember to decrease it, because all the defibrillators, they automatically go to like 120. So you need to make sure to decrease the MAs before you fire away with those. You usually start at around 10. Docs will say start at 10 joules, and then increase from there, and the max is 50 for internal paddles. This is a picture of Juana in an old recess. Working the level 1, which I thought was hysterical, so I found this picture, so I stuck it on there. Use the level 1, try to get them warm fluids, because usually you'll be giving a lot of products to them, so try to keep them as warm as possible. The massive transfusion protocol, Rose is going to be talking about that, but you're probably going to have to initiate the massive transfusion protocol for these patients. If you're doing it in the recess room, try to call over to the that patient looks like they're going to come back. They're going to need to go over to the OR and have some definitive surgery done. So make sure that they get notified and they're aware of what's going on. During the case, a lot of times it's a bloody mess. They'll ask for like multiple suctions, so you may need to hand them like they'll already, there's one in the kit they'll they'll have a sterile yanker and suction tubing in the kit, and they'll say, hook me up, but you may have to like throw another one on them just because a couple of people might be retracting and holding and trying to get all the blood out of there. And every time that I've been in one, and they've always been like penetrating chest traumas, they've always, I swear to God, needed a Foley catheter. Because all they do is that they find the hole, they stick it in there, they blow up the balloon and pull it tight, and that gives them time to do everything else and then fix that, get rid of all the blood and everything and then fix the actual wound. So, things that you're like, well, what do you need a Foley catheter for? A lot of times they'll ask for one, so just just kind of think about that when they're doing it. Remember, we do one-on-one, FFP and PRCs. All right, once again, just like Moana did, go to the nurse, wear all your PPE because it's going to be a bloody mess. I remember Rita Barton, I don't know if any of you remember her. She started the same day I did here. Her very first day on trauma, very first day, I was not an 8-hour night. So I came in at 11, I see her running with the patient, into the elevator. I'm like, how's your first day on trauma? And I looked at her, and she had glasses on, they were streaked with blood. And she's like, I am not having a good day. Her very first patient that came in, they cracked her chest in the resus room. So it happens, trust me. Wear all your PPE if possible. The last time I was in one of these with Toby, of course, it was during orientation. Patient comes in gray, and this was with Bregman also. He was like, we need to get the guy just had access on the side. They're like, he just turned like this in the elevator, one of those deals. And he was in there before you could say boo. The patient wasn't intubated, the patient was in nothing, and the patient was filleted open. He's like, So he was actually technically very quick and very good, very calm. But ultimately, Abraham Lincoln.
They want the little Abraham.
Who is this?
Southern boy, Texas.
So, but you should try to intubate these patients before they do it. When they're actually in the left side, when they're actually in the left side of the chest, a lot of times the lung gets in the way of them doing everything. So they might want to push the ET tube all the way into the right main stem and just ventilate that side for a while. So you might have the doc asking, RTs and the anesthesia people to do that for you. Let's see. Try to make sure to put an NG tube in the patient. And I didn't know this, but they say that if the NG tube's in there, when they're sitting there about ready to cross clamp the aorta, we don't have. It's not like there's a brown tube that's the esophagus and a red tube that's the aorta. It looks kind of all the same. And so that's how they can differentiate between the aorta and the esophagus, is that they can actually palpate the NG tube in there. So try to get that in early. If the patient gets cross-clamped, they try to keep it less than 30 minutes. But just remember, everything distal to that is having less flow. That's mesentery, kidneys, bowels, spine. So you may have some after effects from having the lack of circulation below the level of the cross clamp. So kind of look for that after they come out of the OR or on the unit. Just a few little factoids. Standard CPR is only 20% when you're doing on the chest. You only get about 20% of your normal cardiac output. When they're doing open heart massage, they say it's up to about 55 to 60% of the body's normal cardiac output. So when the patient is really doing poorly and you're coding, even though just open heart massage is just much better than the regular external compressions. I already talked about the paddles. The MD might ask you to hold off the massive fluid resuscitation until the bleeding is controlled. So a lot of times you'll have you have your level 1 going, and they have like a big hole like the subclavian or something, and it's just pouring into the chest. So they'll be like, can you slow that down until we get control of the bleeding and patch up a couple holes here, and then you can start up again. They may leave the chest open sometimes. With multiple injuries, they'll have open chest, open abdomen. If you ever have to do one with Bruce Potenza, please, you don't want to, because he always seems to have to go to the right side of the chest also, and end up with this big clamshell, and it's a nightmare, but a lot of times they'll leave the chest open and then go back for a closure, just like they do with the abdomen. Oh, just remember when they come back to the ICU, they'll be acidotic, cold, and coagulopathic. Try to warm them up as much as you can.
We're dead.
Or dead. Unless they're like if they're a nice person, they'll be dead. If there's some nasty gang member, they'll be perfectly fine.
Well, we'll be fine. We'll be waiting for you.
I'll never forget that when I first started
20 years
here,
ago.
I had a kid that came in who was deader than dead, and it was with Dr. Winchell, and he's like, he opens up his chest, he's like, his heart's empty, you know. Let's not even bother doing anything until we get some fluid in him. So I remember we had the level 1, and we're going, he wasn't doing anything, the heart wasn't beating, we're just kind of sitting around. All of a sudden, we watched the heart start to fibrillate. He's like, all right, let's get the internal paddles, and he goes, poof, the heart starts beating, you know, and that was when we had to do our own CP, the card, remember it was like bypass. We had to do the bypass machine, the CPS machine, remember?
Oh, God.
So I remember like
Wow.
putting all that stuff together, they put them all bypass in the room, it was a hot mess. I came back the next day going, did he survive, blah, blah, blah. And they're like, oh yeah, he's in room 4, screaming about, I didn't fucking ask you to save me. He was extubated, he was like perfectly fine, but a jerk. Of course it happens, right? So just remember, a lot of times they may come in from the field, and I think that when I first started here, the paramedics weren't really allowed to call codes out, patients who were dead out in the field. So they would scoop up the dead body, and they'd come in here and we'd crack the chest. So we were cracking chests left and right when I first started here. But now they call a lot of them in the field, and they never come in. And a lot of times if they do come in, and if it's a blunt trauma, they've been CPR for 20 minutes, we'll just be like, and we feel bad for the paramedics because they do such a great job out there, but they're like, no.
Although Laura opened a couple when we were under construction in room 11, she opened a couple of chests in the trauma bay. I think it was good practice, even though, they were still kind of alive, and I thought that was good practice for the team, though.
Yeah, absolutely.
That's why we did it years ago.
We do it more than.
And I think that-
Like Santa.
We used to do it a lot.
Yeah, and I think that
we did it a lot.
Oh, yeah,
But-
it's
but
like
we-
all the time.
Like that.
we've had a pretty big string of it. I know that I don't think it was the group before you, it was with Toby and all of them. Oh my God, they had like crazy orientation. All right, anything else? So survival rates with penetrating traumas are actually relatively high, 37 to 60%, but pretty much zero in blunt injuries. They're finding out that of course a lot of these people have, either big strokes or anoxic brain injury and cerebral edema after this. So a lot of times we'll save the person, will do such a great job, and they'll end up having like just, having anoxic brain injury and bad cerebral edema or really stroke out after it. One study showed that only 5% of the patients arriving in shock, so actually having good vital signs but in shock, left neurologically intact, only 1% left intact if they actually lost vital signs somewhere before you crack the chest. So I think that we actually have I've seen some pretty good results with some of the patients we have. So I think that we're kind of kicking the trend because we do such a good job in there. But the national averages are really low for people coming back normal.
Are we still the only one that does the OR resus?
Yeah. And that's one of the great things, because like I said, my expectation is for you not to know, to be a scrub nurse. I remember we had one with Raul, and he's like, I think you guys should know how to load sutures, blah, blah, blah. I'm like, no, that's not our job, But I also had one at one night when they asked me to go get the Bovie. And it was great. It must have been a slow night or something, because the OR nurse was like, oh, do you need help in there? And we're like, sure. And the scrub nurse came and did all kind of, loaded all that kind of stuff and ran the Bovie. They're like right in the recess room, and then went over to the OR. So who knows, you know, call over to the OR if you're having something like that.
Yeah.
Maybe someone can help them do stuff like that, because it was pretty a hot mess. We had an intern, like, he's like, I need that loaded and I need this, and it was just bad. So it was really nice to have that. And that's one of the great things about having an OR recess. Their sterile side is on the left side of the chest. They have all the equipment they need. They have a scrub nurse. They have a circulating nurse. You know, it really is, when you have this type of patient, we have the best setup, you know, for us to be successful in it. So I think we do a really good job. I don't have anything else to say. Is that any questions or anything? All right, great. Cool. So the next thing is down there. We're just going to switch. So you can tell them to come in here and then we'll all